Um, Greetings, everyone. It is so nice to see you all here virtually. Thank you very much for joining today's meeting. Please share where you are watching this webinar from in the chat box. And as you know, that this webinar will be followed by a non-graded quiz. That means that we are not going to consider any certain score, since the quiz is just for your own practice and for the purpose of certification. So the quiz is a simple one. I've made it using the Google Form, so it's very easy to handle. All you have to do is to click on the link that I will be sharing the chat box later during the session, and just submit the quiz. And your own personalized certificate will be emailed directly to you. Please share where you are watching this webinar from in the chat box. And during the webinar, please use the chat box to share your questions, which will be discussed at the end of the session, like always. And it's so good to see you all. Thank you very much, Dr. Marvin. Greetings from Pakistan as well. It's great to see you here on the news webinar series. So we will be starting in about 26 minutes from now, which is the right time of the meeting. And as you know, that Professor Daniel Walsh is a very eminent professor of neurosurgery from the King's College, and it's an honor to have him with us today. So please stay tuned. We will be starting in 24 minutes from now. So please use chat box to share your questions during the webinar. Thank you so much. Hello, sir. Welcome. It's so good to welcome you again. Sir, I hope you can see me and hear me. I have also made you the co-host for the meeting so that you have all the control of the Zoom and your slides. But if you would like to just test your PowerPoint, you can, if you may like, you can proceed with it.
Okay, yep. You able to hear me okay?
Yes, sir. Thank you very much, sir, for joining today.
Not at all, no problem.
Thank you so much, sir. It's so good to see you again. It's a matter of real honor, indeed, to have this privilege of learning from you again today. So thank you very much for spending time from your very busy schedule.
Not at all. I'm just going to share my screen so we can establish that you're able to see my slides. How's that?
Sir, it's perfect. Perfectly fine, sir. Thank you very, very much, sir. So I think that we've got 10 minutes to go, but I can very well understand your very busy schedule. So if you like, we can proceed with the webinar a little earlier because the attendees will keep on joining through the meeting. So
Um,
if you
I'm,
say,
I'm happy to start when everyone was expecting, so don't worry. I always come 10 minutes early to check the AV.
For sure, sir, but it's okay. Because everyone is quite excited to see the speaker, so I hope they can join in. And as you know, that this meeting is also being televised live on my YouTube channel, so many of the attendees are already watching it on YouTube as well.
Okay, no pressure.
Thank you so much, sir. So I've received a lot of wonderful feedback from all of the attendees of your previous talk, from your previous talk, and everyone was so excited to see you again as well today, because the topic is of great importance to us, and many of us haven't got much experience. Many of the people around here, so like a few days ago, we held a live workshop here in Lahore for spinal vascular malformations. So we have got Professor Akil Pabani from Emory University. He's a Pakistani, but he was visiting Pakistan to deliver his talk. So we somehow requested him to deliver lectures and perform live surgeries here at PINS as well as another hospital here, tertiary care hospital. So I had the honor of organizing that meeting with one of my wonderful seniors. She's also a woman, so we were like three ladies organizing this whole thing. And we were so excited to see those cases, all those cases, and how the hybrid surgery works and everything. So it's so exciting for me to hear your wonderful perspective. I've already gone through your wonderful research on spinal vascular malformations and your website, in which you have nicely written all the things that you do and all those perspectives. So I'm myself so excited to listen to your talk today.
Not at all. I was planning to pitch it as sort of an overview of the topic. And maybe spend a little bit more time than usual on the more common aspects of dealing with spinal vascular disease. Um, but yeah, but I'm not certain what everybody's level of experience is. It is a difficult thing to get a consistent surgical experience in, I realize. So I, like everyone else, learn from exchanges with colleagues in the area as well. It's a relatively small surgical community who's interested in these things.
Oh, it was so very well, but the thing is, many of the young neurosurgeons, from my perspective, because I'm myself a young neurosurgeon, so many of the young neurosurgeons actually do not have this opportunity of seeing so many surgeries, especially in our part of the world. You can see there's a lot of politics inside the OR here in our country because I think neurosurgery is still in infancy in the developing part of the world. So sometimes it gets very hard for the younger ones to get to see complicated cases and the major cases because of such type of I will say the OR politics. So many of my colleagues, which I now see, they have basically some like they are really interested to know more about all these, especially in cerebrovascular surgery. They are all quite interested, but they, I believe the only problem here is that they do not have the chance to get to see it and to get to learn it. And so you might be amazed to know that in Pakistan we do not have any special like subspecialty training programs. We do have just general neurosurgery, and we learn general neurosurgery and get exposed to whatever cases our hospital is getting. I've been trained at PINS, which is considered the largest dedicated neurosurgical center, and it's located in Lahore. And we would receive like aneurysms and AVMs and everything. But again, the thing was how much we can get a chance to see those cases and to get scrubbed up and observe or assist the cases. So I believe that this is a very major issue in our part of the world, in the developing countries. So somehow through these lectures, many of the gaps, at least academically, have been bridged between at least like the exchange of knowledge. So I believe that it's something. Very beneficial in that means because interest level is so much, and I believe there's a lot of talent here which is somehow get wasted because of this sort of thing that is being underplayed.
Well, I think it's true the world over that with the paradigm shift towards endovascular treatment, microsurgical experience is difficult to accrue. But with regard to what you're saying about general surgery, don't forget good vascular neurosurgery is very often just good cranial neurosurgery, done well. Um, and I think if you're interested in the disease, the world over, healthcare systems are undergoing a rationalization. So I think fewer of us are doing these sort of procedures, or we're trying to centralize them in some way and maximize experience and make it consistent for surgeons who are interested in doing it. And we should remember that's by and large a good thing for patients. So what we can do, as a neurosurgeon learning this trade, you've just got to make yourself available to the experience and go and get it. Don't wait it to come to you.
Exactly, exactly. So this is the way it is because you have to make sure chances, and many people try to do that, but I believe there's a little more encouragement that they need to see, which I think that many of the times things are being changing positively. I think like people get a chance to listen to people or to have some sort of optimism, but this is what we can have and what we can promote and do it. And I think these are the factors which I have myself seen and faced. And although I don't believe that these things, as you very rightly mentioned, things won't come to us until we make our own path. So that's what we have to do. But
Bear in
again,
mind,
sir, I don't.
my generation didn't have the opportunity to go on YouTube and listen to Robert Spetzler or Michael Lawton or Atul Goel or pick a name. Who are coming forward with all these innovations and with large experiences in rare diseases. This generation have the opportunity to hear from these folks day in, day out now. And that would have been just amazing to me as a neurosurgical registrar back in the early 2000s or late 90s. So there are good things as well.
Exactly, sir. I believe this is the way it is. But sir, I also believe that endovascular, as you like the all this neurointervention, is certainly a very important technique. But it is not the answer to every lesion, because I believe that sometimes there is also misconception, especially among the young neurosurgeons who are in training, that endovascular is the answer to every cerebrovascular presentation, that every cerebrovascular disease can be treated through endovascular means. But I believe that it is very important to know that what microneurosurgery is, and I believe that they need to have to first ace all the cerebrovascular surgical procedures before embarking into neurointervention. And I believe that every neurosurgeon should be hybrid. He or she needs to know neurointervention, him or herself. And this is how we can actually provide the best treatment, because every patient needs a tailored approach, especially in such complicated situations.
Well, that's a very interesting and complicated topic, which I would need a whole different slide set to address on another day, perhaps. But yeah, it's a very yeah, we're going through a period of change, which is what's needed. That means we're evolving, and if we're evolving, that's generally good. But you're right. We need to find a way to preserve microsurgical experience so that when it's needed, it's available.
Exactly, sir. Sir, we actually have the cases that we had in our life surgery, where many of them had some failed embolization before, and it was something that was quite um, exactly, very, it's very worrisome for many of us, because those patients have undergone an embolization before, and they were not doing great. And some of them had some incomplete embolization, which recruited, especially the dural areas, which recruited more vessels. One of them was being supplied by the artery of Adam cubics, and it was a really challenging case for us to operate on later on when we had the case. And I think that. And there was some very interesting case, and I think it's not very uncommon, that many of the neurosurgeons are not well accustomed with the dural AVS, and he operated him for a lumbar disc herniation. And the patient was young, and everything was quite like on MRI. I think everything was quite telltale, but probably he had never seen or read about it, and he operated him for a coincidental disc that was there. And he said it's just a simple lumbar disc, without thinking that there are flow whites present in the T2, and there was also the quad edema that was quite evident on MRI, but he missed out that finding. So I think that this is another thing that we need to, how much we need to educate others regarding the right diagnosis and picking up the right treatment option. And like neurointervention is not everything, and we need to also correlate the clinical findings. I think many of the people are nowadays treating the scan instead of treating the patients, and many of them would just miss out the what the normal history was and what were the physical findings, the radiological findings that could see. So again, sir, I really wish to thank you all. I had the privilege of hosting Professor Robert Spessler twice and Professor Michael Lawton twice as well. So it was so good to listen to them as well, and to you. And like I always say, that I have this honor of listening to you during those COVID days, and I was so much intrigued at how much you actually worked on your students and on FRCS exam and everything. It was so fascinating for me. I was so much inspired for all this, for all your work. So I'm so happy to welcome you again.
Okay. Well, it sounds like I'm definitely going to address some of those questions in this talk, I hope. Um,
Thank you.
so should we get underway, do you think?
I guess, sir. I guess it's the time. We are all 2 minutes up already. Okay, sir. Thank you very much. Sir. The floor is all yours. We do not have any sort of time restraints. I usually have this one speaker webinar only to allow the speakers the time they really deserve and wish to have, because all of the attendees are regular attendees and they wish to listen to speaker as much as they can. So the time is all yours. But would you like me to say just a little brief introduction of yours? Although you don't need any introduction, but would you like me to proceed with a very brief
Yep.
introduction?
Yep,
Thank you
please.
very much, sir. Thank you so much, sir. So again, welcome everyone to the news webinar, and it's an honor to welcome the esteemed Professor Daniel Walsh again to the news webinar series. So, as we all know, he doesn't need any introduction, and all of us know him so well. And we are still admiring your previous webinar with the news. So, but for the sake of formality, I would like to say a few lines for introduction. So, Professor Daniel Walsh is consultant neurosurgeon based at the King's College London, and he's an expert in cerebrovascular neurosurgery. He has served as the regional training program director for neurosurgery and as a co-director of the Neurovascular Surgical Fellowship Program, which was the first of its kind that was being recognized, accredited by the Royal College of Surgeons of England. So it was a big thing. He has served as president of the British Neurovascular Group and presently sits on the board of the European Association of Neurosurgical Society's Vascular Section. In 2017, he was appointed the clinical lead for NHS England's Specialized Commissioning Transformation Project on non-traumatic intracerebral and subarachnoid hemorrhage as an advisor to NHS England High Risk Low Volume Neurosurgery Working Group, as well as the visiting clinical senior lecturer at King's College London. He's currently the associate editor for the vascular and pelvic surgery at the British Journal of Neurosurgery, as well as carrying out reviews for many other major clinical journals. And we, as like I have already mentioned, Professor Wash has published so many wonderful research papers, and all of us who are interested in cerebrovascular surgery have certainly gone through Professor Wash's paper at any stage of our life, and still there are references for many of the things. So again, thank you very, very, very much for sparing your time. Although you have a very tight schedule, I know that, but it's really appreciable to see your dedication towards neurosurgical society, towards neurosurgical education, sir. Thank you very, very much for joining us today. The floor is all yours.
Okay. Well, thanks very much for having me once again. Um, the topic I'm going to cover today is pretty dear to my heart. It's a disease I've been lucky enough to encounter relatively frequently throughout my career, and I thought I would just present an overview of the current state of the art, as it were, in relation to the diagnosis and surgical management of spinal vascular malformations. And it sounds like some of this will be complementary to what you've been discussing this week at your course in uh, there in Pakistan. Um, so what I'm going to try and address is I'm going to begin by talking about classification systems, which if you open the book on the first page is what one runs into in spinal vascular malformations. And you usually have quite a lot of people, I suspect, would close the book at page 2 because it seems ridiculously complex. I'm going to try and simplify that a little bit and then talk a bit about our investigation paradigms that we've developed in our unit that we find helpful. And I'm going to break the pathology up basically into diseases that recruit from the dural or extrinsic blood supply of the spinal cord. And I'm going to distinguish those from those that recruit exclusively and shunt into the veins on the spinal cord itself, or the intrinsic blood supply of the spinal cord, which is a far rarer lesion. And we'll, along the way, put in some unusual examples of these sort of clinical problems. It's true, I think, to say that quite often the challenging part with these diseases is sometimes making the diagnosis, and the surgery can be relatively straightforward once you've unraveled the angiography and you know what needs to be done. Um, that taxonomy I was talking about there are multiple systems that have been suggested over the years, and I would refer you to this very, very nice review in the Journal of Neurosurgery by Perry Black, who went through the history of the taxonomy of spinal vascular disease, right from Virchow and Krauss and Ellsberg all the way through to more or less the present day. But even since this was published in 2006, there have been some quite significant changes to those systems as well. And it's quite common with trainee neurosurgeons who are discussing this with me, often to get a little bit mixed up between one system and the other and conflate them. Um, Black describes something called the American, British, and French system, which is, I think, the system that most of us use as the vernacular when describing arteriovenous shunts. We need a system that meets the needs both of surgeons and of neuroradiologists. So the surgeons tend to be somewhat more fixated on the anatomical location of elements of the arteriovenous shunts, whereas it's often our neuroradiological colleagues who are the first to appreciate the pathophysiology, how the blood makes its way from the artery to the vein and what veins there are, which veins are normal and which veins are malfunctioning. So I'm choosing to call that American, British, and French system the international classification, which I think is a little bit easier to say. And it now contains five elements. Um, the first being spinal dural arteriovenous fistulae, which account for about 80% of the spinal vascular lesions dealt with. Um, Type 2s are analogous to the peel AVMs we talked about in the brain during my last talk. Um, the three is the rarest of the lot, which is a rare genetic condition that involves not only the tissue, neurological tissues, but dural linings, muscle, bone, etc. as well, and mercifully is very, very rare because we don't have very good treatments for it. Um, Type 4 is a relatively new addition recognized by René Ginjan and people like Roberto Heros in the early 80s. Um, Often initially confused with dural AVFs with very similar structural MR findings, but in actual fact, the arteriovenous shunt is taking place on the cord, and it's a malformation of the intrinsic blood supply. And at the end, I'll just touch on the very latest addition to the family, which is the spinal epidural fistula type 5, which has also been subdivided into those that have intradural drainage and those that do not. So, even accounting for all of that, you still meet exceptions that sort of overlap the pathophysiology. So, for example, if one has a Conyard type 5 cranial dural arteriovenous fistula, the venous drainage, by definition, for that pathology is into the coronal veins on the brainstem. And those coronal veins are in direct continuity with ventral and dorsal coronis venous plexuses on the spinal cord, so they can induce ischemic myelopathy as well. So that's somewhat analogous and deserves consideration. And then there's this entity which is sometimes a little bit difficult to put in a box. I tend to think of it as a peel perimedullary fistula because it usually does involve the intrinsic irrigation. And it can be lying on the filum terminale, or I've even seen examples within the filum terminale itself. So I'm sure that system will alter more as the years go by. Um, I want to give honorable mention to a suggestion from the group in Bicetra who proposed a more etiologically focused classification on the arteriovenous shunts that are commonly seen in their practice. There's more of an emphasis on congenital and pediatric malformations than the adult practice most of us deal with. Um, but I think this is worth being aware of as well, in that it splits these diseases into those that are hereditary and non-hereditary, and then focal malformations, which may themselves just be incomplete expressions of other diseases. Now, the gold standard investigation for any spinal vascular malformation remains to this day a spinal angiogram. But a spinal angiogram is not a straightforward thing to do. Obviously our interventional neuroradiology colleagues are very, very skilled at doing it, but technically it's got some particular challenges of its own. Whereas in other branches of neurovascular surgery, that cross-sectional vascular imaging has uh, often supplanted catheter angiography, certainly in European practice. Um, it's not been the case with spinal vascular disease, but we recognize that because you have to interrogate 54 pairs of segmental blood vessels all the way down the length of the neuraxis and the intracranial circulation if you're doing a complete study, um, this will involve a heavy contrast load, a lot of radiation. It's time consuming, so time consuming that it may be difficult for a patient to sit still while it goes on. And you may therefore need to break it up into different sessions or do it under general anesthesia. So one of the things we've been interested in over the years is a way to target our spinal angiography a little bit more easily. And a technique emerged from peripheral vascular practice called time resolve MR angiography. There are different proprietary software packages, or it's described by different names depending on the make of MRI scanner you have at your institution. This one that you've got on the screen in front of you is called a TRIX, a time resolved contrast kinetic MRA. And what's different about this is it's not only resolving images in terms of anatomical location, but also it resolves them in terms of time. So you generate images through multiple slices in the neural axis of and different time points of those slices to take us through the arterial and venous cycles. And what you're looking at there on that screen is an illustration of a mid-thoracic spinal dural AVF. It shows the coronal venous plexus very nicely arterialized in the middle, as you'll see it cycle around again in a moment. So that's proven to be a very useful technique for us because it's helped us reduce the amount of spinal angiography we do per given patient. This is a paper that was led by my neuroradiology colleagues along with us, and we found that we could identify for a spinal dural AVF with 93% sensitivity on contrast kinetic MRA. And then we could locate the level within 2 levels very much most of the time. So that allowed us to target our angiography in a slightly more conservative way. It did have its limitations. It's not very discriminatory of polyfistulous lesions, but thankfully, in most of those cases, when we encountered them, the tricks didn't send us in the wrong direction. It tended to be non-diagnostic. It simply couldn't tell us whether there was a shunt present or not, so one inevitably defaulted to catheter angiography. But in monofistulous lesions, it was very, very reliable at demonstrating the level of the fistula. And these are some examples of the TRIX findings we found for polyfistulous lesions. We moved to a paradigm where we will now interrogate the index levels suggested by the MRA and 2 levels above and below, with a 95% plus likelihood of identifying all the arteriovenous pathology on that using that process. If there's any doubt at all, one has to revert back to a full interrogation of the canal with the catheter angiogram. But where we found both negative TRIX and negative subsequent DVA, the appearances on the MRI were ultimately identified as being the result of neuroinflammatory disease, tumor, or cavernoma. One interesting thing is that we had in the initial study for unsuccessful DSAs that we explored on the basis of the TRIX suggestion, and we found vascular pathology, and in fact, I found quite a few more since that time. Really, as our confidence has built that the cross-sectional imaging is telling us something useful. The spinal CTA also has a useful place as well, and I've seen 2 cases over my career where spinal CTA identified a type 1 dural AVF, where both MRA and catheter angiography had been unable to do so. So if you're stuck and you still have a high index of suspicion, spinal CT angiography can be a useful thing to try. Other angiography techniques that have come into our practice include the use of flat panel 2D angiotomography. You're seeing an example there of a brain AVM, which is having that very detailed CT scan generated during a catheter angiogram. But what it becomes useful for with spinal vascular disease is helping resolve precisely where the peel representation of elements of the vascular malformation is. So you can see there on the right, there's an upper thoracic perimedullary fistula, which is quite ectatic. The angiogram alone is, tells you what vessels are going in and where the veins are coming out. But in terms of planning a surgical approach, particularly in the thoracic spine, you'd like to know how relatively ventral it is in the cord, and you get a lot of detail about that from the tomography. And I'll show you examples of how that's been useful in a little while. Something else we do these days, that even I'm going to make a case for you in a moment that the treatment of a type 1 spinal dural AVF, even in this day and age, is optimally microsurgical disconnection. But your interventional neuroradiologist can still play a very important role when we do the diagnostic angiogram. And we now routinely place a marker coil at diagnostic angiography in the radiculodural branch, which we can then see, as you see on the right there, in the operating theatre in the C-arm. And if you've done any surgery in the thoracic spine, you know how difficult it can be sometimes to be confident you're operating on the correct level. We like to do very minimal exposures on these lesions these days, and having this sort of precision really helps us to do that. So, type 1 dural AVFs, 80% of the spinal vascular lesions that we deal with. And as I said, I'm going to spend a little bit more time on that compared to the rarer stuff. This is essentially what's going on in these pictures. I like to think of this as an arteriovenous shunt, which is occurring within the dural leaflet, that usually around where there's an exiting nerve root. And that then coalesces into a fistulous vein, which then plumbs in and joins the dorsal coronal venous plexus on the back of the spinal cord. That arterializes the vein and that impedes its function. I'm going to show you a little video here that illustrates that quite well. So we're looking at a thoracic spinal dural AVF here. I'll draw your attention to the fact that the veins on the dorsum of the cord are arterialized. They're quite dilated and tense, and that's because there's a fistulous vein plumbing into them here. We're going to use ICG angiography to illustrate the direct flow of arterialized blood into the coronal vein, first of all. And there you see. So all the small arteries on the dorsum of the cord are appearing at best at the same time, maybe even a little bit after blood flow arrives in the venous system. So that produces congestive myelopathy. There's no arteriovenous gradient to allow efficient delivery of oxygen to the cord. Now, I've occluded that fistulous vein with a clip here temporarily. And what one would typically rely on in previously would be visual inspection of the vein. You'd look for crenulation, a change in color. And that's often obvious, but there are situations with lower flow shunts where it's a little bit difficult to be certain that you have in fact treated the lesion. But you see the ICG shows here very, very clearly that now the arteries appear and there is clearly a separate venous cycle. So the normal arteriovenous cycle has been re-established just by occluding that vein. And that's all that's required. You don't need to excise the dura. You just need to close the vein. Dural fistulas, whether cranial or whether in the spine, are diseases of the venous system. And if you close the abnormal fistulous vein that's formed, the arterial recruiters that are flowing into that vein will all regress. You don't need to do anything more complex than occlude the vein where it's formed. And that's conceptually very important. So my consultant career certainly has been bookended by two meta-analyses of the outcomes. This one in 2017 reported outcomes of endovascular treatment of dural AVFs, which is, neurosurgeons of my generation, endovascular treatment had found a place in most elements of what I do. So I wasn't surprised that it would be tried out here. But pretty consistently, it was being demonstrated in 2017 still to occlude the shunt less reliably than surgical treatment without necessarily giving much in the way of safety benefits. And I just draw your attention here to the numbers of retreatments required within the two groups. And look also at the complication rates. It's a small series, but there is a difference there. And sort of my beginning of my consultant career, certainly when I was training, Steinmetz produced a study which pretty well reached the same same conclusion. They did a small institutional study of 19 patients. They did a meta-analysis of the published literature and reported 98% obliteration rates with surgical treatment versus 46% um, with endovascular. Um, that didn't really seem to impede the willingness of doctors around the world to try and treat dural fistulas endovascularly. And I certainly see a lot of patients who've been told this is the standard of care. I'm going to try and persuade you it might not be. This is a publication from two centers, one in the US, one of our sister units in London, by very excellent team of interventional neuroradiologists and surgeons. Um, and it again compares a series which is predominantly treated endovascularly with a small surgical series. Unfortunately, most of the surgical patients were lost to follow-up. But I draw your attention to the clinical failure rate of 17% and the ultimate successful obliteration ranging from 46 to 72% in the endovascular arm, although the conclusion was ultimately that this therefore was a viable alternative for patients. Is there any harm, perhaps, in not immediately closing the fistula? Should we be thinking of surgical treatment, being more invasive and therefore something we should be reserving for second line if endovascular treatment is unsuccessful? Well, I think we should probably be challenging that idea. Um, Here is another very nice review, I think, which I think is probably about the most comprehensive done to date, from the team at the Mayo Clinic in Rochester. And again, they've done a systematic review and meta-analysis of all the published literature up until its publication in 2019. And the first thing to say is that consistently to this day, treatment failure is less likely after surgery. So we haven't really changed that, moved the needle on that since 2007. Um, the other important thing is that the chances of neurological recovery are significantly higher in surgical series. And the authors postulate that the reason for that is looking at the number of retreatments and importantly, the lead time to retreatment is that most of the patients who deteriorate while awaiting ultimate obliteration. And that can end up translating into weeks and months. This is a disease that often presents late in the first place. The median time to diagnosis in my series was 18 months, by which time patients had usually been around having very exotic investigations for neuroinflammatory disease or been treated with steroids empirically or what have you. And it took some time for their scans to meet someone who thought, could this be an arteriovenous shunt? Um, so think then again how long that cycle might be added by a delay in effectively obliterating the shunt. Importantly as well, they don't identify any significant difference between morbidity between the two modalities. So why would one wish to wait if the patients are tending to deteriorate during the lead time? This is a study that looked at longer term outcomes from treating a dual AVF. And I always say to my patients, we can't really expect things to go back to normal, however quickly we diagnose you. Although I do personally treat these as emergent. As soon as I'm referred a patient, I will make arrangements for them to be admitted, angiogrammed, and operated on more or less in one admission. Um, because you do see improvement in all the elements of what's called the Amanoff-Logue score. This was the treatment of a type 1 dural AVF, as we presently understand it, was first successfully done uh, in London with Valentine Logue, as far as I know. And it was based on the recognition by Amanoff that there was a single vein contributing to this shunt. Prior to that, in Krause's time, one was thinking of stripping the coronal venous plexus off the whole length of the cord. But developments in angiography allowed the identification of these single fistulous veins and their division. So the Amanoff-Logue score tells us is a composite of measures of gait performance, bladder performance, and fecal continence with its more modern modification. And you can see that what happens is there is a sort of a plateauing. It never goes back down to what would be considered normal, zero. But there's significant improvements over 12 months or so in all of those indices if you can normalize the arteriovenous shunt. And I would suggest, although we can't be sure from the data we have available, that doing it as quickly as possible is likely to be a good idea, inferring that from Goyal's work. This is what the classic type 1 dural AVF looks like. You saw it there with the high signal centrally and flow voids on the cord. This is the MRA illustrating, again, an arterialization of the coronal venous plexus. But what's different in this case is we couldn't resolve the level. So we had to go to full catheter angiography. And what we found at full catheter angiography was a subtype called a polyfistulous dural AVF. So there's two separate fistulas, more than 3 segments apart here. The tricks doesn't lead us down the wrong path. It just tells us I can't tell you where the fistula is. So then the catheter angiogram tells us there's a very slow shunt, and you'll see me exposing them here at the operation at 2 levels. These are sometimes termed type 1B fistulas, and I think there would always something I would consider in the event of a treatment failure as well. If we have treated a type 1 fistula and the patient's swelling is not going down, then we should ask ourselves, could there be another level? What's interesting about this particular case is this poor lady was terribly disabled by an ischemic myelopathy, but the rate of shunting through these fistula is really not very great. Naked eye, you can probably just appreciate that the coronal vein on the dorsum of the cord is not very tense. It's not very congested. But when we do the ICG study here and we open the AVM clips that are occluding the fistulas, we will see a very gradual filling of the coronal vein. You'll see that coming now. This is the upper level. And if you watch the ICG there on the left, it sort of meanders down. It's not very high pressure, and I've edited it a little bit there to move it along. And this is the lower level as well. And when we open the shunt, again, it's not the immediate filling of the vein you saw in the first ICG, is it? But there is very gradually a filling of the whole coronal plexus, and it goes to show that even a low pressure shunt is capable of interfering with the delivery of oxygen to the cord in a very profound way. Most spinal dural arteriovenous fistulas are thoracic or lumbar. However, they do occur in the cervical canal, about 5% of the total. And they are a group worthy of consideration in their own right, because for some reason, dural AVFs in the cervical canal seem to be more prone to developing venous ectasia and hemorrhage, something that you rarely, if ever, see with thoracolumbar lesions. You do occasionally see ischemic lesions as well, but the reason for bleeding is evident from a case like this, where you can see the amount of ectasia that's developed. This patient had presented with a subarachnoid hemorrhage in actual fact. And uh, unfortunately, one of the slides seems to have disappeared. But at surgery, we operated on that through a far lateral exposure. And the principle is precisely the same. You've got to close this vein that's developed and coming out of the venous aneurysm. And this shunting here, this is within the dural leaflet. And that will involute once this vein has been closed. Okay, so we'll move on then to the type 2 arteriovenous malformation. A lesion like this you'll recognize as something of a homologue to the Peel arteriovenous malformations we see perhaps more commonly. And like our AVMs of the brain, we can divide these into compact and diffuse niduses. The nidus being the interposed immature network of vessels that most of the time will not contain functional neurological tissue within it, but you do see mixed versions with compact and diffuse elements. The rate of flow through intramedullary AVMs is often considerably less than with their counterparts in the brain, to the point where there are even some authors who've described the resection of these AVMs by starting with occlusion of the draining vein and working backwards from there. And I've certainly done that on occasions myself, and it can be very effective. Most of the time, we're trying to identify arterial inflow and venous outflow in much the same way we would anywhere else. And in a situation like this, where the compact nidus is within the cord, it requires a myelotomy in order to extirpate the nidus for us to be confident we have relieved the AV shunt. This was a case that had presented with a very nasty high cervical intramedullary hemorrhage. You will occasionally be faced with remnants. And this was one case of mine where I found myself with a quite a diffuse remnant, having had a very compact element resected below. Um, and this is the other unique point about intramedullary AVMs. We understand their natural history even less well than we do AVMs in the brain. But the threat from residual seems to be less, perhaps because of that relatively lower flow. Um, and with a case like this, we mulled over giving radiosurgery, talked to the patient about it. Um, Ultimately, we decided to just leave it be, and that patient went a further 10 years now, without any further hemorrhage occurring, having presented with a hemorrhage. In fact, presenting with two hemorrhages over a short period of time. But the removal of part of the AVM seemed to change that. Of course, it's a case series of one, so you can't really draw confident conclusions with such small experiences, and that's characteristic of the literature in this area. One will see lesions that present to the conus and then extend through the cauda equina as well. With a lesion like this, the presentation was actually with an ischemic conus syndrome. And at operation, what we actually found was the distal part within the cauda equina had more or less thrombosed completely, triggering a swelling of the conus that made the patient deteriorate rather quickly. Um, and using ICG through conventional spinal approach, ultrasound is very useful. The goal with something like this is simply to isolate the malformation. It has a peel representation, and you dissect it away from the cord in much the same way you would with a brain AVM. But what if we are not as confident where the peel representation of the malformation is? Um, This is a teenager who comes with a gait abnormality and continence problems and has the appearances in the MRI. You can see there's a degenerative scoliosis associated with some vena cava compression too, and again a conus syndrome associated with this AVM in the conus irrigated by a large artery of Adamkowitz. Now, Professor Spetzler would probably identify this as a subtype of intramedullary AVM that's uniquely amenable to surgical treatment. Um, uh, when I'm going to operate on something like this, I ask myself, well, this is, T12, L1. I want to know where the peel representation of it is. I know that where the artery of Adamkowitz is going to be, but it would be nice to understand where the rest of the AVM sits in the, to plan the surgical exposure. So when we look at the MRI on the left, you can see it's a little bit of a hot mess, isn't it? It's quite difficult to tell what's conus, what's cauda equina, and what's AVM. But here again, the tomography really helps clear that up. And we can see in this case that there's this ventrolateral presentation to the left of the nidus. So from this, I know that in this case, a costotransversectomy, give me a ventrolateral exposure of this, is going to show me everything I need to isolate this AVM. And here you see that approach. We've opened the dura, we've sectioned the dentate ligament and just very gently rotated the cord around. You can see the nidus there. The ICG illustrates very nicely the anterior spinal artery going into the top, and we can disconnect that very precisely, and you'll see that the ICG afterwards shows resolution of that AV shunt. This is a diffuse AVM, though. This is not something that I'm ever going to be able to actually resect a nidus from. So can we treat these surgically? This is a problem for my endovascular colleagues, and I should have said that most of these AVMs, these intramedullary AVMs, are probably being favored for endovascular treatment, including in our institution. But there are cases that come along like these where we really don't have another good treatment for it. And the role of radiosurgery really remains to be established. There's quite significant rates of cord toxicity in our experience. Um, so it's not something you can just default to. This is a young woman who had two transient episodes of tetraparesis related to small volume hemorrhages at C2. And she had a diffuse AVM irrigated by a branch from the vertebral artery and draining into the coronal vein. There's very diffuse nidus between them. Um, Again, the cross-sectional imaging isn't very helpful in telling us where the substance of the AVM is. You can make out the susceptibility related to the previous bleeding in the cord, but very little else. But if we look at the tomography, we're able to identify the afferent artery and the formation of the draining vein from that diffuse nidus within the cord. And this opens up an opportunity to do something called an in situ disconnection, because we can identify all the peel afferents and all the venous drainage on the peel surface, and we can access them. So we don't have to remove this nidus. And this was something that was initially explored by Professor Spetzler and his team at the Barrow for upper cervical AVMs, I think. And it's proven to be a really, really useful technique for us that patients tolerate far better than any other attempt to remove the AVM. So here we've got a far lateral exposure of the upper cord, and you can see on the ICG here a reproduction of that angioarchitecture I just described. The diffuse nidus is hidden in there. The artery goes in here. The vein comes in here. There are no other veins or arteries to contend with. So we can isolate that just by disconnecting those vessels. And we were able to do that. And that lady woke up with no deficit and never had another hemorrhage. This gentleman presented with a subarachnoid hemorrhage. This is another area of controversy. Um, do you image the spine in patients who've presented with subarachnoid hemorrhage? There's a lot of literature out there suggesting that it's very low yield and therefore that you shouldn't bother. I think in the last 17 years in my practice, we've identified something like 6 patients with spinal vascular malformations who presented with subarachnoid hemorrhage. That's something we should write up. But as a result, we routinely image the whole neuraxis if we do not find a cause for cisternal subarachnoid hemorrhage uh, in the brain. And this was a case in point. The cause of the hemorrhage turned out to be this anterior spinal artery aneurysm associated with a diffuse AVM, again in the ventral cord at C1. We approach that through the same far lateral exposure. And you can appreciate on the surface of the cord here this vascular busyness consistent with the diffuse element of the shunt. But there in the background and focused on here in the inset, that is the aneurysm. Um, we're able to use the ICG to orient ourselves to the vascular anatomy, comparing it with the vein. And the aneurysm is a little bit more difficult. I wouldn't assume that that aneurysm has thrombosed based on that from other experience with aneurysms in ICG, because it often if there's a small bit of thrombus in the wall of the aneurysm, it can be a little deceptive. So I'm sure the aneurysm's alive at that stage. And we isolate the shunt with some micro AVM clips here. And when that vein disappears, now I can be confident that the aneurysm is trapped. And what we did then was just pop a needle into it to make sure it was gone. And the control angiography showed complete obliteration of the AV shunt as well. And he made a very nice recovery. So this in situ disconnection technique, I think, is really, really valuable. It's been a really useful addition to the surgical options for these patients that is probably not often considered. Type 3 malformations, as I said, rare, thankfully. These are metameric malformations, and the current terminology refers to spinal arteriovenous metameric syndrome, or SAMS, a homologue of craniocervical arteriovenous malformation syndrome, CAT 2 and 3. Um, the metamer, of course, is a functional unit of development in the developing, and the I've only encountered two or three of these lesions, well, four actually. I saw one recently. Um, where you are mostly confined to palliative management in some way, either partial embolization, on very rare occasions, partial surgical resections as well. Um, the particular challenge being that they will involve the muscle, the bone to varying degrees, even the skin. Um, and they're mostly about palliation for a lot of these folks. But the presentations I've seen over the years have included ischemic myelopathies, compressive radiculomyelopathies, and even high output cardiac failure in a relatively young woman with a very extensive hemibody malformation. Perimedullary fistulae are, I would suggest, the second most common entity that we encounter, although that's coming under threat from type 5s at the moment, now that we know that they're there. The perimedullary fistula are typically PL fistulas developing between the anterior spinal arterial axis and the coronal venous system on the cord. And there are subtypes which have been described based on the size and the degree of venous ectasia associated with them. These giant polyfistulous ones are sometimes quite easy to confuse with what the Spetzler group would term conus AVMs, and I do sometimes wonder whether those are sometimes used interchangeably. Um, they're often amenable to endovascular treatment by the transarterial route. But if that's not successful, they can be really good surgical targets as well, because if we can identify the precise point of arteriovenous transition, then we can very precisely divide it on the surface of the cord with no risk of, for example, refluxing into normal veins or occluding proximal arteries more than is necessary. This is a case that played into our hands really by being predominantly situated dorsally, but still there was a degree of supply to the conus basket distally that it was felt made this less than ideal for transarterial embolization. And at surgery, we're presented this on the dorsum of the cord. It was relatively straightforward matter to disconnect it at the fistula's point, and as you see, the swelling in the cord goes down very nicely. Occasionally, we've encountered these, and we've not been able to describe their architecture on angiography. Here's a case in point. We have a person where we've got a high index of suspicion that there's an AV shunt causing these appearances. If you haven't encountered this disease a lot, this is the sort of case where I've seen people referred for very prolonged investigations for neuroinflammatory disease. I've even seen one gentleman undergo a stem cell transplant into his cord overseas, on the presumption this was transverse myelitis. Um, what we did here, we'd done two diagnostic angiograms. The problem was aortoiliac disease. We couldn't get distal enough with the catheters to get a good quality angiogram. We tried all the tricks that the radiologists had. You can go through the brachial arteries, you can go through the wrist, you can try different maneuvers, but we just weren't able to identify this AV shunt. So in many of these cases, and I showed you in the tricks paper earlier, we would give some thought to exploring if we could get a clue from the cross-sectional imaging where we might be able to identify pathology. And here, again, with the help of CT angiography in this case, this was the area where our radiology colleagues felt the busyness was greatest and it would be useful to go and look. So we go and look, and what do we find? We find that there's clearly an arteriovenous shunt present. You can clearly see arterialization of veins on the dorsum of the conus there. And using the ICG, we're able to establish that that's a a pretty straightforward perimedullary fistula, which we can divide and normalize the circulation. So the exploration where you've got a high index of suspicion of these lesions is sometimes a very worthwhile undertaking. So I'm going to finish by talking about the newest addition to the family, the type 5 spinal epidural arteriovenous fistula. The appearances of these lesions often mimic um, dural AVFs and indeed perimedullary AVFs. But what distinguishes them is that they usually have a characteristic venous pouch, which is epidural or extradural. Now, some of them will develop aberrant intraspinal drainage as well, medullary drainage. Many of them will not. Um, some of these have been reported in the past. I've encountered a few in the past with compressive radicular symptoms. We've also written up one case of hemorrhage in a child of a purely epidural cervical AV shunt in the past as well. But I think these are the papers I would direct you to for the authorities on this topic. Um, Takai and colleagues are the ones that propose that this really deserved its place as type 5 now that the architecture had been so well described. And they also conducted a study, which I'll summarize in a second, comparing surgical and endovascular treatment in 81 patients in Japan, concluding that surgical treatment was generally superior, although that would be disputed, particularly by the group in the Mayo who've developed transvenous embolization as a means to treat these. And the thing is, these should lend themselves to endovascular treatment quite well, um, because of that epidural situation of most of the venous drainage. Um, I suspect the reason that it's difficult to cure these as reliably as you can with surgery through transarterial embolization of a type 1 fistula is because you have the dural leaflet, which is it constrains the introduction of the embolic agent to a degree. And unless you penetrate all the way into the intradural fistulous vein, you will not cure the fistula. Whereas here you've got this epidural, extradural, if you like, pouch and venous drainage, which you should be able to access very directly with that. And the dural leaflet, in fact, acts as a sort of a shield to keep the liquid embolic agents outside of the spinal canal. So I think I'm not too surprised to hear the very good results that the Mayo team have reported for endovascular treatment of these. And if we do identify them preoperatively, we will generally try and treat them endovascularly first. Here's an example from our practice. In fact, this was a neurologist just at the beginning of COVID who presented with a very rapidly deteriorating conus syndrome. And there's the pouch just ventral to S1, with a venous drainage that then ascends and becomes intradural, seen through an L5S1 laminotomy here. There's the vein ascending after it's become intradural at S1. We divided that and he made a nearly complete recovery. So they can be good surgical lesions as well, and it shouldn't be, but the challenge is to identify that they're actually there. And this is a case of mine where we actually struggled with that and misinterpreted this initially as a type 1. But you'll see that there is this venous, this here, which was initially interpreted as a separate physiological epidural venous structure, is in fact part of the shunt. And the blood circulates through that before irrigating the coronal vein at a much higher level. So if you open up the spinal canal here, you find nothing because this vein is ascending within the dural leaflet, ventrally in this case. But you can occlude the whole shunt by occluding the extradural pouch, which was ultimately the treatment we used in that case. So with that new addition, I'll just remind you that this taxonomy is going to be ever changing, and I encourage you not to be put off by it. Um, it it is a subject that rewards a little bit of study, but once you really begin to unpick the the nature of the arteriovenous shunt in an angiogram, and with fistulas in particular, remember you're trying to identify where the fistulous vein begins, because if you can occlude that, then you will cure the disease most of the time. Um, it's an exceptionally rewarding branch of what we do. So I'm going to finish up there, and on behalf of the ENS vascular section, I'd like to invite any of you listening to come to our Congress in Sofia this year in October. I may have the opportunity to meet some of you there. And if you've got the bug for talking about spinal vascular malformations, I'm boring the internet a lot this weekend, and I'll be talking about the intrinsic malformations in a little bit more detail tomorrow if you have some spare time. So with that, I'll turn back to you and any questions you might have.
Thank you very much, sir, for the very wonderful and insightful talk. And it was very interesting to listen to all the wonderful things that you have very nicely elaborated. And I believe there are a couple of questions in the chat box as well. Sir, there is one thing that I wish to ask you. Sir, do you have your experience with the laser coagulation, which has been in the literature they have written about the laser coagulation of the AVMs, and it may be more useful for AVMs on the limbs, but I don't I really wish to know your view about a possibility of using laser coagulation in spinal AVMs. Is that a possibility?
It's not something personally I've done. My colleague Marco Senzato in Milan is very, very attached to his, I think it's a CO2 laser. Um, and I mean, fundamentally, a laser, a knife, a diathermy forceps, all of these things are a tool to impart energy in some fashion to the lesion and close it. So if you can do that safely without disseminating heat energy, in that case, to the tissue nearby, then I'm sure it would work. The thing is, with a fistulous AVM, you need to be able to identify and access the arteriovenous shunt. So once you've done that, you've done the hard work. And however you divide it, um, laser, shotgun, well, no, that wouldn't work well, would it? But low power, diathermy, micro scissor, micro clip, whatever. As long as you can safely divide that point of fistulation, the job is done. One area I've thought that the laser could be really useful for, and I would like the opportunity to try it out, but it just hasn't arisen, has been brainstem cavernomas. Sometimes solid hemangioblastomas as well, which are a large part of my practice. I look after the cohort of patients with juxta brainstem solid VHL tumors, and I often think the laser could be really useful there. Um, but it's not something I have any experience of with in spinal AVMs, although I'm aware of people using it. And if you really want to know about it, talk to Professor Senzato. He is a big fan.
Oh, really? That's great, sir. Because I read about it and I was a little fascinated with its use. So I've been thinking if it could be really beneficial in case of spinal AVM. So there is also another interesting thing, like I have mentioned before, that many times it has been misdiagnosed and even not treated correctly, and sometimes people do misdiagnose it as lumbar disc herniations, and like not lumbar, but I mean disc herniations, and even spinal stenosis has been diagnosed. So there are also some papers that actually indicate that spinal stenosis and disc herniations can be a cause of spinal dural AVFs, because they think that it is the cytolocal inflammation and also some type of injury that may lead to spinal dural AVF formations through the presence of spinal stenosis or disc herniation. So, do you believe that could be a cause of later development of spinal dural AVFs? And it's not just not we think.
Yeah. So any form of dural arteriovenous fistula, I think in general, they're in adults, they're acquired lesions, and they're probably acquired in response to some local thrombosis of normal veins. Um, the how in the brain there the channels that open up to facilitate the shunt are generally thought to be pre-existing channels within the linings of major sinuses. So they're physiological channels that are just not normally as full as they are in the presence of a local venous exclusion. Um, in the spine, it's a little bit more difficult to understand because these fistulous veins, as you saw in some of the photographs, are clearly not usually present. They're not part of the normal venous drainage on the nerve root, for example. So, um, but they're because they're usually presenting in people in their late middle age or 60s. Um, they're thought to be acquired. You will have noticed in that video I showed of the lady with the polyfistulous type 1B shunt. She had a lot of sternal wires. And in my own series, I think people who've had midline surgery, whether it's a sternotomy for cardiac disease, aortic disease, or spinal surgery, or midline laparotomies, are somewhat overrepresented in those who've presented with dural AVFs. But um, so I think there probably is a link there. Of course, it's not the case. You know, it's only a tiny minority of people undergoing those procedures would suffer this complication. And I did meet one gentleman who presented with a spinal dural AVF. I remember him, he's from Derbyshire, and he told me his father had the exact same thing at about the same age, which rather confounds that theory, doesn't it? Um, but yeah, we believe most of them are acquired in some way, and the beginning of the process is probably thrombosis brought about by some insult.
So it's very interesting because one patient that we received quite a few years ago, it was basically a intracranial spinal, not a spinal dural AVF, it was a cranial dural AVF, but he had the history of a head injury that was treated conservatively. It was not even he was not operated, and he had that dural AVF inside his head, and he had a lot of tinnitus, which is a classical presentation. And for this tinnitus he presented to an ENT surgeon, and that ENT surgeon actually treated him uh, thinking that first of all he thought that he has got tinnitus external, and then he was treated for like an local cause. And after when he didn't get any he was not like satisfied with the treatment from the ENT surgeon, so he later presented himself to a psychiatrist who treated him for psychological issues. And he said that because he has got a history of a head injury that he acquired, he's having some sort of like flashbacks and etc. And after so many, like it was a very long time when he presented to us, it was the real cause was discovered. And he was later on treated by our neuroangio suite interventionalist. But it was very and it was a new case. I actually cited it. I presented it during the link conference with Jock Murray, and Professor Jock Murray was the basic presenter over there. I actually do not actually. It was like back in 2018, and it was a very interesting case because he has a history of head trauma, although he was not operated upon at any stage, and the head trauma was not like very it was a mild one, but it was there was a history over there, and he was presented to us very late. So and so there is also some cases of spinal dysraphism and the presence of AVMs, which is quite rare. But do you think that there is a correlation out there?
Uh, oh yeah, well, spinal dysraphism, there's a definite association, particularly in my experience with perimedullary fistulas and AVMs. And I've operated on diastematic cords that have an AVM sitting between the two cords, for example. Um, Going with regard to what you just said, I mean, these things are always easy diagnosis in retrospect, aren't they? But you get
Yeah.
you get turned down a direction. As I said, I've seen people go through quite remarkable investigations. I've seen the opposite as well. I remember seeing a patient who reached me and was sort of thought they were at the end of their journey of their diagnosis. Finally, it was a spinal AVF, and in fact, what was being looked at on the MRI was an artifact created by a fly that had gotten into the coil during the scan. Um, there, but for the grace of God, go any of us. And as I said, often the most difficult part of this journey for both patients and doctor is making the diagnosis. Once you're confident of the diagnosis, the treatment can sometimes be deceptively simple.
Yes, it is basically, when God really has wills to get the treatment, and I think it depends upon individual surgeon's own experience and own competency level, and it's like
Well,
luck of the
exactly.
patient.
If you've seen it before, you think of these things. But bear in mind, if you're in an ENT practice, you've seen people with tinnitus every day of the week. You might never have seen somebody in that circumstance present in that way. So why would it occur to you as a differential diagnosis necessarily? Um, and we get referred these quite a lot from our ENT colleagues. Again, because of the centralization of experience, everybody begins to realize that this is a possibility. I've also just your question about disc prolapses. Something important that I don't know if you've ever encountered, but to consider in a situation where you see a disc prolapse and an ischemic cord is
Yes.
sometimes you will have metameric blood supply to the cord. So as the artery of Adamkiewicz is the most common one, artery of the cervical expansion, but there can also be a metameric vessel in the lumbosacral canal. And there have been cases of compression of that artery by prolapsed discs that produce conus ischemia. Of course, that's not an arteriovenous shunt. It's a direct result of the compression. But again, if you've never heard or seen an example of it, it wouldn't occur to one. Um,
Thank you very, very much sir, for this very elaborate account. I think that everyone is so, especially of my generation, is so lucky to have this privilege of listening to you through all these talks and everything. And I think there is so much to think about for the doctors right now, because they can have all those things here directly from masters like you. They can hear it, they can learn about it, they can ask about it. I believe that it's a very huge privilege for all of us to have this opportunity of learning from you. And I think basically, neurosurgery is a very, very vast field in that way that we have to ace our academics, because, we can have something that we have never seen before unless we have already know about it, and that means that we need to have a lot of exposure and think about it. So there are a couple of questions. Would you like me to take?
yeah, please.
So there's a question from Professor Martin Buttilli. He wants to ask, please comment on considerations and means of disconnecting shunts. Once the trial clipping has proved that you have the right spot.
Um, Concentration, do you mean in terms of liquid embolic agents and things like that?
No, sorry, considerations. Please comment on considerations and means of disconnecting shunts once
Oh,
the trial clipping has provided that you have the right spot.
yeah. So then I would just use low powered bipolar diathermy. And generally don't leave a clip in afterwards. I fulgurate back to the dural leaflet. I'll fulgurate the inner side of the dural leaflet, but it's not necessary to do anything more elaborate than that. Excising part of the dura and so forth. Um, I think I used to say that would be something I'd reserve for recurrent cases, but to be honest, I don't think I've ever done it. Um, so it's that element of things is quite straightforward for a fistula. With an AVM, again, I would rely on very sharp knives, very small instruments. I use microanastomosis instruments for dissection of PLAVMs. I like the diamond dusted graspers as a dissection tool with those. I think they're really useful for it. And a diamond knife and an ophthalmic knife, which I use to do as much of the resection as I can, and also format them. Midline myelotomies are generally avascular if you're in the right spot. Um, So, and then once you come to the AVM itself, one is you're trying to find a vessel to disconnect and start removing the nidus, whether, and that can be an artery, but it can sometimes be a vein, too. And you can use the vein as the tail to lead you, or lead the AVM nidus away from the rest of the cord. More and more, though, I'm seeing AVMs that really lend themselves to the in situ disconnection technique, and I think that's tremendously useful. I could have gone on for another hour showing videos of what is essentially quite a simple thing to do. But the key is just to assure yourself that you understand the anatomy that you see on the cord so that you can be confident you're not going to do any harm. And of course, we use neurophysiology as well in all those cases to give us a clue. I like using the micro AVM clips as temporary occlusion too, so that I can check if there's any change in D wave contact electrodes. After we do that. And to be honest, we found that to be a very safe approach.
Thank you very much, sir, for this very elaborate question. So there is another question over here, sir. Sir, this is from Dr. Marvin from Nicaragua, and he's sending you wishes and asking you, what is the biggest challenge in the surgery of intramedullary malformations?
Well, like I said, I think it's again, it's not in the operating room necessarily. It's the diagnosis and making a good decision when to intervene. Um, the with such a rare pathology, it's terribly difficult to assemble the experience. You have to get a little bit lucky in order to assemble the experience that makes you feel confident that you're always doing the right thing. If you just assume that all of these lesions should be operated on, you're likely to do some harm. So I think a multidisciplinary framework is incredibly useful. I enjoy, I like to think, really good relationships with my interventional neuroradiology colleagues who are very expert, but we all try and leave our egos at the door if we can. And we try and give an honest appraisal of the balance of risk. And very often we'll talk to the patients together to say, here's what we can do. No one in the world really knows if, what the optimal option for you is, but here's the strengths, here's the drawbacks of each approach. What do you think, um, to the patient? Involve the patient in the conversation as well. Once you've designed a treatment, then as I said, the technical execution of the procedure, if you've understood the anatomy correctly, is probably not the most difficult thing that we do. But it's getting to that point.
Exactly, sir. It's a whole lot of like how much can be how much that can be paid at each and every step. So right from the first, like you have very nicely mentioned, from the diagnosis and knowing the patient and all the approaches that we.
Tune in tomorrow night for more details of that.
Oh, yes, sure, sir. I'm going to certainly go through that, and I would be so interested to mo watch more of your surgical videos because those are so wonderful. They are so much insightful and I guess very helpful for everyone who has been in the OR and who has even not ever seen these surgeries before. Even for them, I think it's very insightful, and I really wish to thank you so much for your wonderful lecture.
Oh, my pleasure.
No, sir, I guess it's a huge privilege for all of us because we now can have this very huge opportunity of learning from you. Like I have mentioned before, and I think this is something that we all could ever wish for inside of our minds before, and it's like it's getting so much real. So there are so many compliments and so many messages of thanks for you in the chat box right now, and everyone is so much thrilled to have this privilege of listening to you again. So again, thank you very, very much. And sir, I also wish to thank you for delivering your lectures on weekends. I know it's very hard to like accommodate a weekend for education, and it really inspires me to think that how much dedication you really show for a neurosurgical education. And I can believe that obviously sparing a weekend is a big thing. So, sir, I again wish to thank you, especially for sparing your weekend for this talk.
Not at all. I can see from the chat we've got people from everywhere from Afghanistan to the Fiji Islands. Isn't that amazing?
It's so amazing, sir. It's like a global village over here, and like you have said, from each and every part of the world. And there are people on my YouTube channel as well who are watching, and it's so amazing, sir. And it's like your message is being echoed at each and every corner of the world. And I've been actually writing, and there is someone from Senegal
Yeah, I
right
see.
here, and
Algeria.
this from Australia. And so I've been actually writing to one of my colleagues. He was writing that it's so good to be here, and I can see so many people. I said, okay, even the aliens can watch us if they can tune into Zoom. Because it is so much global, it is beyond global. It can be even watched on the ISS, that is in the sky. The space station can see us, and they can relate to the aliens as well. So it's such a big privilege. I think that everyone can see. It's so accessible, and the recordings are, sir, I was so impressed to see that people have a lot of interest in all these things. And all those recordings that are on my YouTube channel are being reviewed several times after the live show, and everyone is interested to see those recordings. And I think, sir, it's all because we owe you up huge thanks, and it's all because of you that you always give a lot of importance to neurosurgical education, and your message is really echoed at each and every part of the world. And when I was talking in my hospital, and everyone was like, we saw that. We saw that lecture, and I had the privilege of listening to that professor, and everyone was so fascinated that they had the chance. So thank you very much, sir. I think thanks is a very small word. We cannot put it into words what we actually feel and the benefit that we really have from all these lectures.
Always. Well, have a lovely weekend.
Thank you very much, sir. Have a wonderful weekend ahead. Thank you so much again. And,
Oh,
sir, I really wish to have the privilege of inviting you once more once you have more time.
I, I'll be happy to help.
Thank you very much, sir. Thank you very much, sir.
Okay, take care. Bye.
I think that all of you have received link to the quiz. Please submit this quiz. It is a non-graded quiz. You don't have to score some particular percentage to get this certificate. You just have to submit this non-graded quiz. It is a Google form type of a quiz, and after the submission of the quiz, you will receive your certificate right into your email, automatically generated through the artificial intelligence. I also wish to thank everyone. If I have missed your messages, thank you, Dr. Pizat, Dr. Irion, I don't know, he's right here. Dr. Everyone who is here. I really wish to thank you all for joining us today, and I hope to see you all on 7th June with Professor Pascal Jabor, and he will be discussing some recent advances in the treatment of cerebrovascular diseases. So I'm so excited to welcome you to Professor Pascal Jabor's lecture on June 7, 2024. That is next month. And please to join it. And I also wish to tell you that the news network is global, and it's for everyone, and it is totally free. Every activity that I introduce is free, and it's also free of sponsorship. We do not have any sort of sponsorship on that because we want to keep this platform very, very accessible and free. And I think that my focus is on the low middle income countries, but it is open for everyone. And like you can see that people from every part of the world are are here, and it's so amazing. It's so beautiful to be here with all of you. So again, thank you so much. And I also want to reiterate the fact that all of these webinars have a certificate, and for the certificate, it is a prerequisite to submit your quiz. And this quiz is for your own practice only and for the purpose of certification. So it is a non-graded quiz. You don't have to score anything. You have to just fill the form and submit it. And your certificate will be emailed directly to you using the AI. Again, I wish to thank you all, and I hope to see you on June 7th at 7 a.m. EDT. That will be about 4 p.m. Pakistan time and 1 p.m. CEST. And you can just see the details